welcome back to Anesthesia Coffee Break. So we've had a bit of a hiatus for a while, but Archie, you've come back with some neuro.
Yeah, I've come back with a little bit of neuro. Neuro is not something that's talked about a lot, and I think it's a really fun topic. So I'm hopeful that everyone enjoys it as well.
Fantastic. So this is just one of those syllabus points for the primary exam. Outline the anatomy of the cerebral and spinal cord circulation. So just to get started, tell me about the blood supply to the brain.
Yeah, awesome. So I think this is something that we're going to keep coming back to, but there are certain numbers that are really important and are crucial to neurophysiology of the brain in anesthetics and in our primaries. So the standard number to remember sort of around the cerebral circulation is about 50 mils of, so this is the cerebral blood flow equals 50 mils for every 100 grams of brain tissue per minute, which in a normal human equates to about 750 mils per minute on average, resulting in about 15% of cardiac output.
Fantastic. And so a lot of the time, when I studied this, I'd just line up all the organs and just list them from top to bottom, just so I'm remembering them comparatively. So remembering the brain to the heart, to the kidneys, to other circulations. And it's often in mils per 100 gram or total. And like, I've got to be honest, I tried to remember both of them because it's all part of a table. So mils per 100 gram, mils per minute, and then percentage of cardiac output. So maybe as a challenge, I'll just keep asking you that throughout this, and just so the listeners can also reiterate the fact that it's 50 mils per 100 grams of brain tissue per minute, or 750 mils per minute, or 15% cardiac output. And if there's a range, just remember one number. The examiners don't really care about the fine detail of that. Keep going.
Yeah, so I guess everyone knows that the brain has a really high O2 consumption rate. So even if there's an interruption in the cerebral blood supply for about 10 seconds or so, this can cause unconsciousness. Cerebral ischemia is thought to start occurring when cerebral blood flow is less than sort of 20 to 30 mils per 100 grams per minute, which leads to a lot of these cerebral disturbances that can be permanent if not reversed within, say, about 3 to 8 minutes. This is because there's lots and lots and lots of demand, but not all that much storage around the cerebral circulation inside the brain.
Yes, it seems like a really bad equation for the potentially the most important organ in the body. Lots and lots of demand, not much storage. And as a lot of us know, as soon as you get any kind of problem, whether it's a trauma there or near trauma or any kind of blood loss, you'll have issues. You'll have loss of consciousness. So tell us about one mechanism where the body can compensate for the fact that there's potentially really challenged supply to the brain.
Yeah, so the brain supply is done through, we will all know as the circle of Willis. This blood supply is divided into anterior and posterior circulation, and it allows for collateral circulation between the two and between the left and the right sides of the lobes as well. Under normal circumstances, though, there's sort of not that much that goes from one side into another because the perfusion pressures are almost equal for both sides. So there's not a huge gradient from a high pressure situation to go to a low pressure situation, but usually it's kept fairly constant.
Fantastic. Tell me about the posterior circulation.
Yeah, so the posterior circulation supplies the occipital lobes, the cerebellum, and the brainstem, and it's supplied by the following arteries. So we'll go through the arteries. The first branch is the vertebral artery. These are small arteries sort of that branch from the subclavian arteries. These are the first sort of big branches from the subclavian artery. So we might remember our mnemonic VIT CD from med school, and V for vertebral arteries. These travel within the transverse foramen of the cervical vertebrae and then travel up. It firstly gives off sort of the posterior inferior cerebellar artery, which is the pica artery. It can be quite devastating if these get blocked, and you can get a specific syndrome, which we won't go into, called, I think it's Wallenberg syndrome. These also give off the very important anterior spinal artery, and we'll come back to that in our spinal artery circulation talk. And moving on, we can do both of these go into combining into the basilar artery, which supplies the midbrain, cerebellum, and usually the branches of the posterior cerebral artery. These can be the ICA, the anterior inferior cerebellar artery, the pontine branches, as well as the superior cerebellar artery. A number of these arteries in combination actually supply the respiratory centers in our brain. So strokes in this area for us as anaesthetists are really important because they can affect how your breathing pattern can be. Then you've obviously got the posterior cerebral artery, which is another main area. And this is then joined to the anterior circulation by what the name suggests, posterior communicating artery. And then we'll go into the anterior circulation in a second.
Great. So just to recap, if you were thinking about the blood supply, we've got the circle of Willis and then the posterior circulation, which is the vertebral arteries, basilar artery, posterior cerebral artery, and the posterior communicating artery. How about the anterior circulation?
So the anterior circulation is, as the name suggests, for the anterior portion of the brain. And it does about sort of 2/3 of the blood supply to the brain. So this is a really big circulation area. It's supplied by the following arteries. So you've got your internal carotid arteries, you've got your middle cerebral artery, and then you've got your anterior cerebral artery that make up all of the anterior circulation. So if I'm going to go into a little bit of detail about some of these, is that in the internal carotid arteries, obviously these are really, really large arteries and are the medial branches of the common carotid arteries, which enter the skull. And these actually enter within the skull. However, their cousins or their siblings, the external carotid branches, which supply the facial tissues, don't obviously do that. Moving on, you've got your middle cerebral artery, which supplies the lateral part of the brain. And then you've got your anterior cerebral circulation, which also contains this little communicating artery, which connects both the anterior cerebral arteries along with the floor of this, along the floor of the cerebral vault.
Right. So I'd say the best way to learn this is literally to Google blood supply to the brain. So you've got a visual image of what the anterior and posterior circulations look like, what the circle of Willis looks like. Now, just to relate it back to the exam, now that we've gone through that, I'm going to tell you it's probably low yield, especially for short answer questions. Definitely when I did my exam over 10 years ago, I didn't see any questions about this, but look at all the short answers to make sure of that. And if it was asked before, absolutely learn this in the detail that the examiners require. I can imagine this being some kind of MCQ and just lay your knowledge, like the fact that you can talk about the circulation, mention the circle of Willis, know that there's a posterior circulation and an anterior circulation. And you can probably remember most of those arteries just from your knowledge of medicine and from med school days. I think for the anaesthetist, now from a clinical point of view, I think the most important thing is actually the posterior circulation. Like the anterior circulation is kind of obvious. We don't have to think too much about that. You're doing a carotid endarterectomy or some kind of carotid operation. Clinically, you want to have some awareness of, well, the surgeons will absolutely want to have an awareness of the presence of collateral circulation and a complete circle of Willis. But from our point of view, it's something we think about as well, because during cross-clamping of these procedures, is the brain going to have blood supply? Will they need shunting? Will they need some kind of a cerebral oximetry monitoring? And there's a whole bunch of things clinically that we look out for. But I think the posterior circulation is far more subtle and interesting. Imagine you're doing some kind of posterior fossa surgery in various positions, in a prone or prone sitting position. You've really got to think, if whatever the issue is to that posterior circulation, whether it's pathological damage like a stroke, or damage or swelling or some kind of constriction from the surgery itself or the positioning, what does it affect? It affects the respiratory centers, and now I've got a massive problem. And this patient may need to go, obviously have this sorted out, go to ICU, intubated. They may not be breathing normally. So back to, because this is definitely one of the questions you'll get asked a lot. What is the blood supply to the brain?
Yeah. So again, as we said, 50 mils per 100 grams of brain tissue per minute, equating to about 750 mils per minute in total.
That's sick. And what's the percentage of your cardiac output?
15.
Fantastic. Now, tell me about venous drainage.
Okay, so the venous drainage, it involves the dural venous sinuses, which lie between the periosteal and the meningeal layers of the dura mater. Important to know that all of these dural venous sinuses ultimately drain into the IJV, which is the internal jugular vein, and the dural sinuses are valveless. So there's no valves within these systems, so it can just go straight down with gravity's aid. So I'm not, again, not too sure whether this is actually the path of it is very relevant, but we'll do it for completion, where the superior sagittal sinus comes off and meets the posteriorly and meets the straight sinus at the confluence of sinuses. The internal sagittal sinus also meets the great cerebral vein and turns into the straight sinus, which, as we mentioned before, meets the superior sagittal sinus at the confluence of sinuses.
Just quickly, actually, the inferior sagittal sinus meets the great cerebral vein. Yeah.
The blood then passes through the bilateral transverse sinuses and turns into the sigmoid sinus, leading to then draining down into the internal jugular vein. So this is really well visualized with a particular diagram, which you'll be able to see. So I think this is another one that you actually have a diagram in front of you and go through the pathway, and it'll make a lot of sense.
Fantastic. So again, best way to do this, Google the venous drainage, and it's so much easier to understand and see. And the names are obvious: superior, inferior. You've got the transverse and straight. It kind of makes sense. Now, again, exam-wise, I doubt this is something that's going to be a major part of a short answer question. Maybe it's going to be an MCQ. It's just not a big deal for this primary exam. But I'd say it's, again, one of the most important things, maybe even more so than the arterial circulation, is the venous circulation. If you're having surgery on the brain for any reason, especially if it's to do with the sinuses, like an arterial venous malformation, the problem with this is that they're dural, and these dural sinuses have the dura, which encompasses each of the veins and can tent the vein open. So if this is sitting position surgery where the sinus is above the level of the heart, and now you've got an open sinus, unlike veins in the rest of your body, which either collapse completely if it's low pressure, or if it's high pressure are full of blood, these ones at low pressure will still remain open, and there's a really large chance that you might get a venous air embolism, and a whole bunch of things will be done to prevent that. So again, clinical correlation, these are really important if you're ever doing surgery in the sitting position near these structures. Now, tell us about the spinal cord, or the arterial supply to the spinal cord, rather.
So keeping it the same, let's just keep it the same. So there's two major arterial supplies. There's an anterior spinal arteries, and then there's posterior supply, okay? So there's one anterior spinal artery, so that comes in and supplies the anterior part of the spinal cord, and it's actually quite large. So it supplies about 2/3 of the anterior circulation, and it lies on the anterior median fissure. The vertebral arteries, as we talked about before, up the top, join up and form this artery at the level of the foramen magnum and travel down the anterior median fissure. However, they receive collateral contributions sort of from the radicular arteries, from the intrathecal vertebral arteries as they make their way down. So there is a little bit of collateral flow, but the main aspect is this anterior cerebral artery.
Mm-hmm. How about the two posterior arteries?
Yeah, so the two posterior arteries then supply the 1/3 of the circulation that's left. It lies on the posterior sides bilaterally. It's paired and supply the grey and the white columns of our spinal cord. Similar to the arterial supply, they also have contributions from this radicular arteries that go all the way down as it comes off.
Fantastic. And there's this one major artery, which, funnily enough, I never even heard about this artery back from anatomy and med school days, but this is a really big deal. In the final exam, there's a whole question of what is the arterial supply. Write notes on the arterial supply to the spinal cord. Tell me about that artery.
Yeah, so this is the artery of Adamkowitz. I'm sure someone will say I'm saying that wrong, but this is it. It's a dominant segmental medullary or radiculomedullary artery, which can give sort of variable origins, but typically it comes off sort of left side and arises between T9 to L2. This artery is really vulnerable to occlusion relating to sort of the pathology of the thoracic aorta. So when there's a dissection or there's cross-clamping, when they're doing the open repairs or any form of cross clamping, it's actually really vulnerable. So the damage to this vessel, because it's so vulnerable to occlusion, can lead to paralysis from the spinal cord infarction, as it's sort of that dominant supply from the to the lumbar sacral cord segments. There will be a little bit of sort of collateral, as we mentioned, way down, but this is the major artery from that bottom. So it's really important to know about.
And a whole bunch of things will be done. If you've got a thoracic aortic operation, the cross clamp is high, you're absolutely going to cut out that major blood supply, as well as, just a lot of blood supply to the lower lower spinal cord. And so there'll be a lot of things that you have to do as an anesthetist, and in coordination with the surgeon. They'll be all very familiar with cooling of the spinal cord, or even putting CSF drains in, and other types of bypass potentially. But really important to know that that's part of the anatomy, and it's in major parts of the artery of Adamkiewicz. And by the way, what is the blood supply to the brain?
So it's 50 mils per 100 grams of brain tissue per minute, equating to 750 mils in total for a normal human. And it's 15% of our total cardiac output.
Beautiful. Now, final part of anatomy that's relevant to us, I guess, is cerebrospinal fluid. So tell me about that.
Okay, so short notes on the cerebrospinal fluid here. There's a lot more, and I found really good detail on deranged physiology, obviously. So it's a really good resource to go to. But I'd say 500 mils of total CSF is produced during the day in a normal human, which means, and there's about 150 mil of CSF present at each time. So there's about a turnover of 3 to 4 times of your complete CSF output per day.
Okay.
Will that be sort of right to you?
Yeah, that sounds right. There's 500 mils production, 150 mils present at any time. What is the role of this mystical CSF, cerebrospinal fluid?
So 4 big roles that I break it down into. There's the mechanical protection from buoyancy, and it's the water weight principle. So because usually our brain is about 1.5 kilos in, again, a normal sized weighted human. And this can be reduced because it floats around in this magical CSF to about 50 grams. So that plays a major protective role in sort of that mechanical buoyancy. So our brain can sort of move around and flush around a little bit inside our cranium. Other things are that you've got your CSF that produces a constant chemical environment, which is ideal for neuronal activity. So as we said, neurons are really sensitive to sort of changes in the pH and whatnot. So it provides a nice little chemical environment, which then leads us into how important it is for acid and base regulation in the control of respiration. So when you go back to sort of studying about your respiratory physiology, we remember that the CO2 is then indirectly transferred through hydrogen ions, and then that affects how we respire, and that's through this principle that we're talking about.
And so the main part of that is the fact that there's very little buffering in the CSF. Yeah. So even though it's this really nice constant chemical environment, it lacks a buffer, which means a very fast response. There's, your CO2 gets transferred, then converts to H+, and that immediately causes an effect rather than in the bloodstream where it'll be buffered. So really important to know that.
Yeah. And lastly, there's hydraulic pressure buffering of the ICP with arterial pulsation and respiration. So that's another really important one to know about. So those are the 4 things that I'll just put down, and then you can write short notes on them if you get asked about it.
Yeah, great. So mechanical protection, so buoyancy, chemical environment, acid-base regulation, hydraulic pressure or pressure buffering. And how is the CSF formed?
So again, short notes on this. Out of the choroid plexus, I think there's a quoted number of about 67% on MAC 95. So choroid plexus on the floor of the lateral ventricles. So lateral ventricles, which then flow through the foramen of Monro into the 3rd ventricle, and through the aqueduct of Sylvius into the 4th ventricle. And then from the 4th ventricle, it can go left or right, or it can go down. So if it goes laterally, it can go through the lateral foramen of Luschka, and I remember that with L lateral for Luschka, and then it can go around sort of the bacilla cisterns and around the pons and rest of the cortex, or it can flow from the 4th ventricle medially and down the foramen of Magendie down into the spinal and the subarachnoid space in there, and M for median.
That's right. Lateral, Luschka, medial, Magendie. Excellent.
Yep.
And it's reabsorption?
Yeah, so then it's reabsorbed back from the subarachnoid space from the sort of granules that are in there. And you've got 90% of it is done by arachnoid villi, and then you've got directly by cerebral venules. It's about 10%. So this can show how important it is when you've got a bleed or you've got blocked like arachnoid villi. You can see how this can cause hydrocephalus.
Yeah, excellent. And what else can you tell us about CSF?
So it's really ultra regulated. So this is regulated by a complex ultrafiltration and active secretion method done through the fenestrated capillary membranes. There's it's as I said, it's done through active mechanism, and there's a number of different receptors and transporters that are involved. Again, if you want to go into that much detail, just go in and have a look at Deranged Physiology. It's got a great notes in there. But for you to know, it's done through ultrafiltration, active secretion method through the fenestrated capillary membrane, and it's promoted by bulk flow and hydrostatic pressure. And now I think that's really important to know, because the formation isn't traditionally affected by ICP unless you've got a drop in cerebral perfusion pressure, which is different from your ICP. If you've got a low cerebral perfusion pressure, it has low pressure supply to the choroid plexus, which then can reduce production. But traditionally, it is done through bulk flow and hydrostatic pressure.
Excellent. Yeah, so that's probably a lot of detail that we've covered from the anatomy side of things. So we talked about the blood supply. There was 50 mils per 100 grams of brain tissue, at 750 mils per minute on average, and about 15% of cardiac output, which is a large part of your cardiac output. We've gone through the circle of Willis, posterior circulation, anterior circulation. We've talked about venous drainage and its relevance. And again, just looking at the pictures, trying to being able to quickly do a diagram showing the arteries and the veins is probably the easiest way to learn this. And then the spinal cord supply, especially the artery of Adamkiewicz, which is very vulnerable to occlusion, as well as such an important part of supplying the lower part of the spinal cord. And then finally, cerebrospinal fluid. I think that's pretty much all we need to cover before we go on to the next episode, which is something extremely relevant for anesthesia and something we've got far more of an active part of management, which is intracranial pressure. So thanks everyone for listening and watching, and please share with anyone who might be interested. We'll see you again next time.
See you, everyone.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.